Thank you, Michael. It's really good to be part of this very illustrious panel. I mean, I'm excited to be one of the many that have are contributing to this program over the next few weeks. Is this a time where I can start sharing the slides?
Yes, so yeah, we're excited to have you. Alzheimer's obviously become a very hot issue in the last, many years as it seems to be increasing. So can't wait to hear what you have to say about it, and you can go ahead and share your slides and get started.
All right. Well, so as Michael mentioned, this talk I've recently did a whole series of actually 8 talks to a large group of doctors and dentists that were very interested in this burgeoning field of Alzheimer's. I recently had a patient come to me from San Diego, where she's been a manager of medical practices for 27 years, the last 10 years for a large neurology practice. And she says they have never seen so many new cases of cognitive disorders in younger individuals, 30s and 40s and 50s, something that would normally take another 20 or 30 years before they would be showing up requesting the services of the neurologist. And so we're really in for a significant challenge in the next few years and decades with this very topic. So what I try to do here today, and this is part of a two-part series. Today, April 8th, and also on the 17th, I'm going to be doing part 2 of this series. So we're going to do as much of this as we can today, and then we're going to take questions from you, and then we'll finish this up next time. So we're basically looking at multiple steps. I called it 10 steps, but really I'm going to be giving you a lot more than 10 steps in testing for, in other words, how do we know whether this is a risk or not? How do we know, is this a serious risk or is this a mild risk? We're going to be talking about that today. But also, what are the steps in actually reversing the underlying causes of Alzheimer's? Inferred in this, we're talking about preventing Alzheimer's in the first place. Okay, but we're also talking about catching things early and catching things at whatever stage you're at right now. Okay, and reversing from there. Okay, so we'll be elaborating on this as we go, but whether you just have a family history and you don't have any symptoms of cognitive decline and you just want to prevent this from ever happening to you, okay, this is for you. Or to the opposite extreme of that continuum, you could be having significant issues with Alzheimer's already, okay, and maybe you're a family member or a spouse that wants to help your family member, your spouse, but they're not able to help themselves because they have progressed so much. Well, that's actually what my book, Memory Makeover, How to Prevent Alzheimer's and Reverse Cognitive Decline, is all about. It's actually a case study of a patient who had Alzheimer's for 15 years already. The last 5 years were advanced Alzheimer's, and their neurologist was saying to the husband, you got to put her in hospice. You're going to ruin your own health if you keep trying to be her primary caregiver. And he begged the neurologist, please, isn't there anything else that we could do? Well, this neurologist was actually a friend of mine from Loma Linda University when we were in school together back in the mid 80s. And he had heard me speak at the American College of Lifestyle Medicine annual meetings. And I was talking on this very same topic because Dr. Dale Bredesen was supposed to do the keynote, but he couldn't do the keynote because he was in Europe. So he asked me to do it. And when he heard me talk about what was possible, he says, wow, as a neurologist, I've never heard about this. So I don't have any experience in reversing things like this. Okay, but he said, Dr. Youngberg seemed to have a lot of faith in this, so I'm going to refer you to him. Maybe he can help you. Well, that's what the book is all about. And bottom line is that after a year on the program, he said, I have my wife back. She went from basically being advanced Alzheimer's in a vegetative state to being able to communicate with him, to be his wife again, have a relationship, be able to enjoy each other's company and go back and forth and discussing things. So she still technically had Alzheimer's, but she had functional level of Alzheimer's. And so in other words, even if you already have a serious level of dementia, these programs, these strategies can really benefit many, many people. So let's jump right into this and start looking at, well, what is the lifetime risk? As I mentioned, I just recently did a presentation for a large group of doctors that in Washington State, and they were baffled by how bad this has really gotten. And there's a lot of reasons for that, but so this study was actually just published in Nature Medicine in January of 2025. And it's basically looking at a large prospective study that was done that looked at major communities across the United States and asked the question, if you're over 55 years of age, what is your lifetime risk of dementia? If you're over 70, what's your lifetime risk of developing dementia yourself? The reality is that more than half of us are at risk. So let's take a look at the study summary real quick. First of all, they were comparing to a previous study, the Framingham Heart Study, which is one of the biggest epidemiologic studies ever done. It's still going on. It started in the 40s, and now it's into the fourth generation, where they basically took the entire town of Framingham, Massachusetts, and everybody got tested. And now their children and their grandchildren and their great-grandchildren are being tested as well. So it's an amazing study where we're learning a tremendous amount of information from getting a lot of data, and we're going to actually be sharing that a couple of the main steps on how we reverse the underlying causes of Alzheimer's actually came from the Framingham study in part. Now, so this study was over 10,000 individuals, and they determined, as they looked at individuals starting in 1975, those who were 45 years or older were added to this study, and they were tracked until 2009. Okay, so basically we're looking at a study that started 50 years ago. And they found that of those men in the study, 14% developed dementia. So the lifetime risk of dementia, if you were over 45 years of age 50 years ago, was 14% risk. It's a lot worse now. I mean, we'll see that. So for women, it was 23% lifetime risk of developing dementia. Now, you'll see in a little bit that women are actually at higher physiologic risk than men per se. It's just that they live longer than men. Men are more likely to die of heart disease or cancer or something else earlier. And so women are still alive and they're more likely to get dementia simply because they're still alive. There'd be just as many men getting dementia if they live long enough to get it. Okay, so the goal is we want to make you so healthy that you don't get heart disease, that you don't get cancer, but also so you don't get dementia, right? Wouldn't it be a shame if we just help you live long enough so that you can spend the last 10, 15, sometimes 20 years of your life with dementia? That's not acceptable. So this new study that was published in Nature Medicine was actually a study called ERIC, Atherosclerosis Risk in Communities. They took 15,000 men and women starting at the age of 55 back in 1987. So we're looking at a study that began a little bit less than 40 years ago, and they collected data up until 2020. Now, what really I want to highlight here is that 35% of men develop dementia. So the lifetime risk of dementia for those that were over 55 years of age back in 1987 was 35%. One out of every three men who started out then, who are 55 or older in 1987, ended up developing dementia. Now, that is more than double what it was for men who started out 10 years before that. So in just 10 years, the lifetime risk of dementia for men more than doubled. Okay, and that's for a study that started 40 years ago. So we're in a lot of trouble right now because this is the risk of developing dementia is going through the roof. Now, for women, it also more than doubled from 23% to 48%. So another one of the stats that was interesting, and I have it here at the third paragraph of this summary. If alive and dementia-free at age 75, in this study, there was a lifetime risk of dementia that was over 50% in the overall population and in almost all subpopulations as well. In other words, for those who were 55 and over back 40 years ago, as they lived their lives, okay, there's one chance out of two that they would develop dementia. Okay, and again, it is far, far worse today. Okay, so bottom line, why women have more dementia? We already explained that. Men were less likely to survive to older age, thus reducing their overall lifetime risk of developing dementia. Now, another couple take-homes of this major study that was just published was that poor access to education. In other words, when you don't have ongoing learning stimuli, you're more likely to develop dementia. Or if you have poor nutrition, either early in life or any time in your life, where you're focusing on refined foods rather than plant-strong foods or natural foods, that those combinations contributed to earlier differences in what's called cognitive reserve. Now, so this is a really important concept because it's like if you're basically working out so that you can handle a certain amount of exercise or even trauma for that matter, okay, that's what we would call a reserve capacity, a strength reserve, where your muscles are able to handle a certain amount of exercise without being damaged or without you being injured in some way. Cognitive reserve is the same in that if we are not constantly building on that supply of cognitive reserve, we start losing that reserve capacity. And so we're going to be expanding on that throughout this lecture as well. But we need to live our lives such that we have every day, we're actually building on a reserve. We're helping maintain that reserve rather than that cognitive reserve gradually being whittled away. So it's the same way. That's why, by the way, that's one of the reasons that strength training is so important as we age in particular. This is not just for jocks. If you're not doing some type of strength training, which can be as simple as doing some sit-down squats in your chair every day, even 10 or 20 of them, if you're not doing something to stimulate the large muscles of your body to stay strong, your strength reserve, your large muscle strength reserve is going to dwindle away, and that is directly not only related to injury rates, but it's direct and fall rates, but it's directly related to the resiliency of your cognition, of your brain. In other words, the stronger your muscles are, the stronger your brain is in resisting things that damage it. So that should be a motivation for all of us to have some level of strength training in our program. More on that in a little bit. And so the bottom line summary of this major study just published this year in Nature Medicine is saying that policies that enhance prevention in healthy aging are urgent public health priorities for reducing substantial and growing burdens of dementia. I could not agree more. That is so critical, and of course, that's what we're going to be focusing on. Now, what I want to draw attention to, this is a couple of the graphs that came out in this study. And the first thing I want to point out is, again, the cumulative incidence of dementia in this study, okay, that started 40 years ago, was 42%. Okay, but you see here on the right-hand side that women had a higher rate of dementia than men, but we explained why, because they live longer and therefore more likely to be diagnosed. Now look at the discrepancy here between blacks and whites. You see that they're actually fairly similar. Whites have a lifetime risk of 41% of developing dementia in their lifetime. Blacks had a 44%, so about 3% higher than whites did. Now, so that is a racial disparity that we hear about. Now, what's interesting, at one of the 10 steps that I'm going to highlight today and we'll talk about later on is the importance of optimizing your vitamin D levels. And it actually applies directly to the apparent racial disparity here and the incidence or the likelihood of developing dementia in our lifetime. And I actually believe, looking at the research, that this disparity of 3% would be largely removed if everybody tested their vitamin D levels and optimized their vitamin D levels, or at least got their vitamin D blood levels above 40 nanograms per ml. Okay, so by the way, most people, unless they're supplementing at least 4,000 to 5,000 units of vitamin D a day, are going to be under 40. How do I know this? I've actually been measuring every patient's vitamin D for the last 25 years. Okay, and that was after I read a study that came out of Harvard back in the early 2000s that showed that the level of vitamin D in your blood had more to do with whether or not you got cancer, statistically speaking, than whether you smoked or not. Now, at first I didn't believe it. I go, that can't be true. You know, I'm a lifestyle medicine doctor, and so I'm very involved in encouraging people to stop smoking. I was trained in 2 international programs to help people stop smoking. And so that was hard to believe, that the level of vitamin D in your blood had more to do with cancer risk than smoking. Now, of course, both of them are very important. In fact, smoking is a big predictor of future risk of cancer. The point is that based on the same statistical framework, actually vitamin D levels are a little bit more important than smoking. That's how important vitamin D is. And if we know anything about vitamin D, the level of vitamin D in your blood is directly proportional to how much vitamin D is produced under your skin when exposed to ultraviolet B radiation or sunlight. And of course, the darker our skin is, the more protection we have against sunlight. And so therefore, individuals with darker skin are much more likely to have low levels of vitamin D, even though they may have the same amount of exposure to midday sun. And by the way, vitamin D only is produced in midday sun, not in morning sunlight, not in afternoon sunlight. The sun has to be at least 45 degrees into the sky before enough photons are basically interacting with a form of cholesterol in the skin that is then electromagnetically converted to vitamin D. Okay, so you can't produce that unless the sun is high in the sky. That's why in the wintertime, most of the United States has a 5-month vitamin D winter. You could be outside all day long and essentially get no vitamin D of clinical significance. So there's something so looking at this, quote, racial disparity between blacks and whites in dementia, okay, the good news is that if we address the vitamin D issue, we largely fix that disparity. That's great news. In fact, in 2008, when I moved from Guam, where I was measuring all my patients with vitamin D, and most of them were low in vitamin D as well, Guam. Most of my patients here in Southern California, where I practice near San Diego, are low in vitamin D. Okay, so most people do not go out into the sun when their sun is high enough to produce vitamin D. So, I had an opportunity to go to a conference in San Diego. It was the very first conference on the clinical applications of vitamin D in medical practice. And the organizers of this conference had brought in experts from all around the world, the people who had done the most studies on vitamin D and the relationship with health. And so I got to talk to literally the top 5 researchers in the world on vitamin D. And well, the reason I'm telling you this story is because the nurses that sponsored the conference were nurses from the National Black Nursing Association. Now, why do you think they were the ones sponsoring the conference? Because the Black nurses knew that it was individuals with the darker skin that were at the highest risk of vitamin D deficiency, and therefore all the chronic diseases associated with vitamin D deficiency. I remember as I walked into the auditorium at UCSD, big auditorium, and there was a whole bunch of Black nurses around. I go like, this is great. And they were handing out the flyers. And it was only then that I started realizing this association. So that's really critical concept to understand. By the way, all of us are at risk of vitamin D deficiency, whether we're Black, Hispanic, Indian, or white. It doesn't matter. We're all at risk. It's just that you're at more risk if you have darker skin. And and then finally in this graph, we have this differential between different alleles of the ApoE4 gene mutation. And so you might know that ApoE4 is the mutation or the dreaded Alzheimer's genetic mutation that is actually very common in the United States and around the world. About 1 in 4 individuals carry one copy of that mutation, which all by itself increases the relative risk for developing developing Alzheimer's by about 300 to 500%. Now, if you have 2 copies of that mutation, or you're a homozygous carrier of 2 copies of that mutation, now your risk just goes up roughly to about 1,200%. So very, very significant. And so bottom line is that we're going to be talking about how genetics plays a role in this. But here's the good news. If you have a genetic mutation, that doesn't mean you're going to have the problem. That just means you need to pay more attention to all the risk factors. And that's how you mitigate genetic risk. Genetic risk factors have historically, and I learned this in school, that they're unmodifiable. It's entirely untrue. Yes, you can't change the fact that you have that genetic mutation, but you can dramatically alter the effect of that mutation that it has on your biochemistry by knowing where it is and what enzymes are involved. And so that's why I recommend genetic testing to all my patients, because it's through genetic testing that you can learn your weaknesses medically and do something about it now before it actually happens to you. So, all right, let's keep going. Bottom line is on this upper left-hand graph here, you see that the expected new cases of Alzheimer's every year is just skyrocketing. Okay, and actually, this graph does not do it justice. It's going to be far worse than this for a lot of reasons that we'll get into. Okay, and then basically, it's important to point out that about 28% of the participants of this study throughout the United States had one copy of the mutation. Less than 3% had 2 copies. So it's quite rare to have 2 copies of the mutation. But about 70% of individuals don't have any copy at all. So that's good news. But there's other genes that increase risk as well, like the TOM40 mutation, the brain-derived neurotrophic factor mutation, and other mutations as well. Okay, so let's keep going here. Now, in this study, they looked at individuals between 55 and 74. I'm smack in the middle of this. I'm 65 this year. And so they're looking at that, basically 20% of men are diagnosed with Alzheimer's between age 55 and 74. Okay, and so that's the average age of diagnosis depending on your age. And so you see that men are much more likely, or 25% more likely to get diagnosed with dementia between the ages of 55 and 74 than women are. So that suggests that we have risk factors, or we're participating in things that are increasing our risk that women are not. So that's interesting. Okay, and so then you look at that blacks are actually more likely as well to be diagnosed with dementia early on. Okay, and I've already explained to you why I believe that largely represents an inadequacy of vitamin D in their blood, which is a huge factor. It's also a huge factor in infections. Okay, it's a huge factor in your risk of dying of COVID dramatically increases if your vitamin D levels are low. Okay, so that's why we got to fix vitamin D levels in everybody. And then so let's go ahead and start getting into the other aspects of this presentation. About 10 years ago, many of you might remember that Glenn Campbell was diagnosed with Alzheimer's disease. He'd been suffering some earlier issues with cognition, but it wasn't until Glenn Campbell actually met with a neurologist at the Mayo Clinic in 2014 that they started doing testing on him, and they actually discovered that indeed he did have Alzheimer's disease specifically. And so if you get a chance, actually you can go to YouTube and just search for Glenn Campbell Mayo Clinic, and you'll see these videos. It's very interesting videos on how they did different scans on him, and they were able to show what a normal brain looks like, what mild cognitive impairment looks like under the scans, and then Alzheimer's disease. Now, in this video that you can all watch, the head neurologist at the Mayo Clinic is explaining to Glenn Campbell and his wife, who was actually videotaping this, he's showing the MRI of Glenn Campbell, and he's pointing his pen to a section of the brain. You see, there's two little sections called, these are the hippocampi, one on the left side, one on the right side. This is the area of the brain that consolidates short-term memories into long-term memory, among other factors. But you can see he's pointing out here that this whole area of the hippocampus, more than half of it is gone. It's basically a shadow. It's just gone, and it's wiped out. And he's pointing out that this clearly indicates that Glenn Campbell's problems with memory are stemming from the fact that the cells, the neurons in the hippocampi, have atrophied, have been destroyed to the point where more than half of them are gone. They're just not they're not just not working, they're gone. They've been destroyed. And so this is a really important part of this discussion as we start looking at what do we do about this, is that the brain is very resilient. Okay, and many people are losing over 1,000 neuronal brain cells in their hippocampi, their memory brain cells, every day. Of course, we have many millions in our hippocampi, but the point is that if we're losing 1,000 every day, that's going to add up pretty quick. And so over time, that we're basically wiping out that whole forest of neurons in our brain where memory is consolidated. So as you'll see here in a little bit, we now have research that says that you don't have to be that person that's losing 1,000 brain cells a day in that area of your brain. You can actually be the person who's growing 700 new memory brain cells every day. How do we do that? We call that hippocampal neurogenesis. And so that's the whole point of this discussion, is how do we go about accomplishing that? So real quickly, a review of what these hippocampi, these are these little centers in the midsection of the brain, the size of their thumb, right in the middle, represents only 1% of the total brain mass, but a critical part, because that's where our memories are converted from short to long term. The only part of the brain that allows us to remember instantly and long term, right there. It requires, and this is the key, it requires daily restoration and production of new free synapses. This relies on supportive daily habits. Okay, so that's why as we get into the steps on how we literally renew or reactivate the brain, and grow new brain cells and create new free synapses. In order to store new memories for today, we have to have produced new free synapses that night. And so this brings up a whole nother topic that would take a couple lectures to really get into in depth, but we call it ego depletion of synapses. So when you have physical or cognitive or emotional overtaxation, that leads to hippocampal exhaustion. I just saw a patient this morning who's struggling with horrible fatigue. And so we're needing to build his reserve capacity up so that he doesn't experience that fatigue every day. But that fatigue is not just physical. It also affects his brain. So he's at very high risk of developing Alzheimer's-like symptoms over time because of this depletion of synapses that he's not building them up properly. Okay, so a couple of other interesting points here is that antidepressants actually increase the production of hippocampal neurons. Now, I'm not saying everybody should go on antidepressants. I'm just trying to make a point here. But blocking neurogenesis, that is the development or the growth of new memory cells, stops the benefit of antidepressants. So the key then, the main point for bringing this up, is that we need to promote all the natural strategies that promote production of new memory neurons. Okay, and that's more than 10 steps, by the way. The Karolinska Institute, they're the ones that basically run and administer the Nobel Prizes for medicine. They say that we produce an average of 700 new hippocampal neurons daily, even as we age. And studies are saying even if you already have Alzheimer's, you just want to make sure that those survive and you're holding on to them rather than them being destroyed along with the other cells. So what are the factors then on how many are produced? Okay, so for instance, depression is actually a neurodegenerative process. Okay, so depression is a symptom that people have, but it's a symptom because the brain is actually depressed. The brain is under assault. And so it was reported to be the highest prevalence in history in 2019, except that in 2020, depression rates tripled. So it was the highest ever in 2019, and then it tripled in 2020. Anybody have any idea what happened in 2020? Okay, so a lot of things happened that were really bad for the brain. And so those are pretty self-evident now. So bottom line is that depression is actually an expression of inadequate hippocampal neurogenesis, where the brain is developing new memory neurons. Okay, and depression all by itself is associated with a doubling risk of Alzheimer's Anxiety recently in studies has been associated with a triple increased risk in Alzheimer's. So we need to address these issues at the cause. Okay, so here's a really interesting kind of heads up as one of the 10 points that we'll get into in more detail in a bit. But there was a year-long study where they randomized a group to walking 1 hour every day versus no specific walking program. What they did is they did MRIs. We call it hippocampal volumetrics. If you're concerned about your risk of Alzheimer's, if you have a family history of Alzheimer's, or you have an ApoE4 mutation, or you have other factors that suggest that you need to really get focused on a comprehensive program, okay, it's a good idea to get the brain MRI and then request that brain MRI be evaluated through what we call NeuroQuant or neural reader software, where the software at the imaging center automatically calculates what the size of your hippocampi are, how much remaining neurons you have in your hippocampi. Okay, and what they found is after 1 year, neurogenesis activated to the point of their hippocampi growing in size by 2%. Now that might not sound like a lot, but it is actually, it's a significant amount, because the average person is going to be the non-walking group. Their hippocampi shrunk by almost 2%. So we're looking at almost a 4% differential. Okay, if you're walking every day or you're exercising in some way every day, your brain actually makes more hippocampal neurons, which are the memory neurons, which is exactly what many of us need, right? Okay, if you're not doing exercise every day, you're losing hippocampal neurons. Okay, so again, if you're concerned about that, if you have a family risk of Alzheimer's, like I do, get your MRI for the brain and do the hippocampal volumetric, which gives you an actual number that compares you to men or women your age. So on a percentile basis. So that's very valuable. Here's an interesting study where the black dots here represent new hippocampal memory cells being formed. Okay, they're stained for just the new hippocampal neurons. And in group A, the controls, these were the mice in this case that did not have a running wheel in their cage. But if you looked at the mice that had a running wheel in their cage, look at the difference. Look at how many more hippocampal memory cells were being produced in the brains of these mice. So bottom line is we can dramatically increase if we, number one, get daily exercise. And it doesn't have to be necessarily hard exercise. The key is to get some exercise. Now, so here, just in case you're wondering, well, where's this data, right? Okay, so here's a study that was published in 2020 in the journal Cell and Stem Cell, that human hippocampal neurogenesis persists in aged adults and Alzheimer's disease patients. So, a lot of people and a lot of families make this mistake. They say, well, my spouse or my dad or my mom, they already got diagnosed with Alzheimer's. It's too late to prevent it. They already got diagnosed with it. So the mantra is like, oh, I'm so sorry. That's like, well, we're just trying to make them as comfortable as possible, put them in a memory ward where they're served all kinds of food, which makes them worse, right? Because sweets and sugary foods actually destroy hippocampal memory cells. Now, I wish that wasn't true. I like sweets and desserts just as much as the next person. Okay, but if we know anything from medical science, from a dietary standpoint, what we consume, what we eat for calories makes a huge difference to brain health. Basically, sugar and refined products and refined fast foods literally destroy the brain. Okay, and so the good news is that by no longer participating in something that destroys the brain. Now we have a chance for the brain to catch up and to start literally growing the cells back that were lost initially. Okay, this is, in other words, never give up. I told you the story of my patient that was referred by their neurologist that didn't know what else to do, and said, well, maybe Dr. Youngberg can help. But he'd never seen that. By the way, that patient had a hippocampal volume that was smaller than the first percentile. In other words, 99.5% of people her age had more cells in their hippocampi. That's how destroyed her hippocampi were. And so, she was kind of in a vegetative state. We kind of expected it to be there. Okay. And yet she improved dramatically over the next months and years. And so bottom line is never give up, even if there's an advanced case of Alzheimer's. There's things that can be done. If you have a will to improve somebody's health, you can. There's many doctors out there that understand this. Okay, now, let's kind of define dementia in functional terms. And so the bottom line here is that dementia is the decline in mental ability severe enough to interfere with activities of daily living. So if you're now having a hard time remembering faces or names such that you're now embarrassed enough where you don't go out to do stuff with your friends anymore or socialize anymore because you're embarrassed about it, okay, that's obviously a major interference in activities of daily living. But less subtle than that are where you used to be able to keep your checkbook and control your finances just fine, but now you have a hard time figuring out your checkbook now. Or you used to be a great cook and now you can't follow a recipe anymore. It's just too confusing. You can't cook, or you turn on the stove and you leave it there and you're at risk of burning the house down, right? So those are just simple examples of functionality. Are you able to get dressed on your own? Are you able to get undressed on your own? Are you able to use the toilet facilities on your own or not? Okay, now this actually brings up a really important point. One of the many excuses that I hear sometimes from family members when we're starting to work on putting together a comprehensive plan is that the family members are going like, man, this is really involved. There's a lot of testing involved. We got to change the diet. We got to get them to exercise. And so they're kind of negative from the get-go because they're going like, well, my dad doesn't want to do those things. Okay. In my book, the husband of this lady had Alzheimer's for 15 years. He said, yeah, my wife doesn't want to exercise either, but I figured out a way to get her to exercise. You know what he told me? He said he knew that she loved to go shopping. Okay. She could not communicate very well. But if he said, honey, you want to go walk around the track or walk around the block with me, she would like shake her head or she could maybe do one-word sentences and she'd say no. But if he said, hey, honey, you want to go shopping, she would go. Her eyes would brighten, and she would shake her head. Yes, she wanted to go. So she would not resist him to go shopping. And so they went shopping and walked around the mall. They would do window shopping, and she would get the same amount of exercise than if they were going out for a normal walk. So he figured out ways to get her to exercise to the point where she now clearly felt better after exercise. And now she was even willing to go walk around the block because she knew it was going to make her feel better. Okay, so that it's a real important part of it. Now, memory is not just remembering names. Memory is not just remembering what somebody said 10, 20 minutes ago. Those are important things. But let me tell you, that is nothing compared to real serious memory problems. Now, you might be thinking, wait a minute, what could be more serious than not remembering something that I was told 10 minutes ago? You know, so family members get very frustrated because their parent or their spouse or family member, they keep asking the same question 20, 30 times a day. And so they're saying that, there's no hope for these people. Well, that's not true. Okay, but even more than that, if somebody is able to otherwise have a regular conversation with you, even if they won't necessarily remember it later on, they're still part of the family and they're engaging with you as a family member. What would be worse is if, and let me give you an example. This is a crude example, but it's a very real example that makes my point. It's what's really worse is where somebody walks into the bathroom in their own house and they have forgotten how to have a bowel movement. And because they have all the urges and they have to go, they literally go in their pants and then they're uncomfortable and they're trying to think, well, what do I do now? I don't know what to do next. They reach back, they pull some feces out and they start wiping it on the sink. They start wiping it on the wall. They wipe it on a towel. Can you imagine the mess? Now I've had more than a couple patients brought to me by their spouses where they were actually experiencing that level of memory loss. And do you know that in every case, within 2 months, they were now able to have a normal bowel movement with good memory on how to do that and how to take care of business. Okay, so they were actually able to regain that function. And so these individuals have such advanced levels of memory loss, okay, that a lot of people just say there's nothing we can do. That is not true. Now, they may never get to the point where they're remembering everything you told them 20 minutes ago, okay, but they're getting to the point where they're part of the family again. They're enjoying your company. You're enjoying their company. They're able to function in other aspects of their daily living that previously they weren't able to function at. Okay, so memory loss, there's a continuum that most people don't think of. And so when you're thinking about a family member, oh yeah, they already got the diagnosis of Alzheimer's. They're already not remembering what I told them 10 minutes ago. So there's really nothing that we can do for them. That's actually really bad thinking. Okay, the reality is we can dramatically stave off all the worst aspects of memory loss while we're gradually improving that as well. Okay, so that's why I wanted to give you this kind of definition, this functional definition of dementia, because it has to do with being able to participate in family life in a functional way. That's critical. That's critical. And we can regain much of that even in advanced Alzheimer's in some cases. Now, there's actually a lot more to this than the symptoms of dementia. So let me show you here. I recently did, actually a couple years ago now, I did a presentation for Wellness Coaches of America. So for which is one of the top coaching academic organizations in the world that they train health coaches. And so they brought me in as kind of the expert in this field. And so that's why the slides are a little bit different here. But I explained to the health coaches that there's a continuum of cognitive decline. And the first part of it is what we call pre-symptomatic neurodegeneration. Now, what this implies is that there's actually physical pathology in the brain, in the hippocampi of the brain, okay, and yet there's no symptoms. Well, we know that, for instance, did you know that even before you meet the official diagnosis of pre-diabetes, which a huge percentage of the population has, but has never been diagnosed? Why? Because no symptoms. You have to do blood tests to figure this out. Okay, so but even before somebody meets that definition of pre-diabetes, they have already lost close to 50% of their ability to produce insulin. And you can actually measure that functionally with different tests. The beta cells of the pancreas that make insulin have actually been destroyed or damaged up to 50%. Now, we can still regain that, just like we can regain cells in their hippocampi or regrow or repair cells in the brain to help memory. The same thing happens with diabetes. And you'll see in a little bit that diabetes could actually be referred to as Alzheimer's of the pancreas because it follows the same type of pathology. The infection or toxin or stress on the pancreas causes the beta cells of the pancreas to make amylin, very similar to beta amyloid in the brain, okay, and that amylin kills the beta cells that make insulin. Okay, so the very attempt to get rid of an infection or a toxin in the pancreas is actually destroying the cells that make insulin. Okay, so that's exactly what's going on in the brain as well. So you can have significant pathologic damage way before there's any symptoms because it has to do with reserve, right? That's another way to understand that is that you could have trauma to one of your kidneys where you actually lose that kidney. It has to be removed. It could be cancer, it could be an accident of sorts. You still got one kidney, and you're fine as long as you keep that kidney healthy, right? So the body is very resilient. The brain is very resilient. The pancreas is very resilient. But that's why we got to take care of it so it remains resilient. So pre-symptomatic neurodegeneration. In a little bit, I'm going to show you some tests that you can do that will tell you whether you're pre-symptomatic. Because none of the memory tests are going to tell you that you're pre-symptomatic. In fact, the memory tests don't even tell you if you have subjective cognitive decline. Because subjective cognitive decline, you do the Montreal Cognitive Assessment Test or the St. Louis University mental state exam, and you score really well. You get 30 out of 30 or 27 out of 30, and you're considered normal. Okay, but if you know, based on your own experience, I'm not as sharp as I used to be, you have subjective cognitive decline. That's how we determine it. Okay, I remember I had a very, very wise and smart network executive come to my office, right here in this office. And most of my visits I do on Zoom, just like this, okay, because I have patients all over the country. Okay, but he actually drove in from LA. And he told me, I always ask people what they do. And he said, no, I'm a network executive. And then said, so how can I help you? And so he kind of talked about his pre-diabetes and his diabetes. And after 20 minutes, he finally came around to the real reason he was there is because he was concerned about his memory. And he told me, he says, I confided in one of our executive board members that was a good friend of his at the network. He says, man, I'm really concerned about my memory. And his friend says, what are you talking about? You're like the smartest guy at the entire network. And of course, he said to me, I didn't say this to him. He said to me, yeah, I know. I know. I am the smartest guy at the network. But the problem is that my memory is declining. So even with declining memory, you're still the smartest guy at the network. But that didn't matter. See, because cognitive decline or Alzheimer's has nothing to do with how smart you are. It has everything to do with how things are changing from your previous abilities. And so he said, I could go into a board meeting and I could remember things that had been decided 10 years earlier in board meetings. So when they would argue about what had happened at a previous board meeting, they'd eventually get to him and say, okay, what really happened? And he'd verbatim tell them what happened, and they'd accept it because he had that level of memory. And I said, well, hey, good for you. I've never had that type of memory. Okay. But the fact that you no longer have the memory you used to have is a real red flag, right? Because that means there's neurodegeneration going on with what you had. Okay, so he had subjective cognitive decline with significant pathology as well. Now, and then when you start doing the testing, and you're testing lower, you lower on the scale, you have mild cognitive decline, which there's nothing mild about it. That's really serious. That means it's really a more advanced pathology. And then when it gets bad enough, then it goes into Alzheimer's or other forms of dementia. Okay, so here's an example of the Montreal Cognitive Assessment Forum. Okay, where, for instance, you're naming animals. You gotta name the animals accurately. A lot of people, instead of saying rhino, will say hippopotamus. Okay, so that's -1 right there. You got to draw a cube. You got to draw a clock with the clock saying 10 past 11, and that you can have really smart people that just can't do that. It shows that spatially they're not all what they thought they were. Or drawing the cube. I had a really smart attorney come into my office, and I asked him to draw a cube. He couldn't do it. He was still really good at doing what he did as an attorney. He just couldn't figure out how to draw a cube. That means that something's not going right. We need to jump on this. Okay, and then remembering 5 different words about 5 to 10 minutes after you've heard them, and things like that. So bottom line is, if you score at least 26 on this 30-point scale on either the Montreal Cognitive Assessment or the St. Louis University mental state exam, then you're normal. In other words, normal is defined by what an average high school graduate can do. Okay, it's not optimal. That's just normal. Okay, so now if you drop down under 26, that is called mild cognitive impairment by definition. Okay, and if you're between 19 and 22, that's normally would be mild cognitive impairment. But if you're now starting to experience difficulties with daily activities, now that's actually early Alzheimer's or early form of some type of dementia. Okay, and if you're under 19, then it is clearly dementia. 80% of the time, dementia is Alzheimer's related. By the way, that's the main one you want to have. You don't want to have frontal temporal. You don't want to have Lewy body disease. You don't want to have some of these other rarer forms of dementia, because those are much harder to deal with. The second most common type of dementia is vascular dementia, which usually has a component in Alzheimer's as well. Okay, so here are our goals. Our goals are to, number one, and I tell this to every time I see a new patient who has either family history of Alzheimer's or has genetic issues associated with it, or has early subjective cognitive decline, or has already been diagnosed with something. I tell them this. Number one, our main goal is to slow down progression. Now, many of them will say, wait, I didn't come here to slow anything down. I want to reverse it. Yeah, but you can't reverse it unless you first learn how to slow it down. Okay, so we believe that 100% of individuals that are in an Alzheimer's or a mild cognitive impairment continuum can slow down cognitive decline. We'll show you studies proving that. The next step is that, or goal is that we want to stop progression. So you want to slow it down enough where it's no longer building, it's no longer progressing. We believe that we can do that on average about 90% of the time, or even 95% of the time. That's big, because historically, neurologists did not even believe that you could prevent dementia, much less stop it, okay, much less start to reverse aspects of that cognitive decline. So ultimately, we want to basically show benefit functionally, okay, and on testing and on scans that we're actually doing better. And we now have the technology to do just that. So there's another form of symptomatic or memory test called CNS vital signs, which is far more sensitive than the Montreal or St. Louis tests are. It's much more elaborate. And so if you have early tendencies to mild cognitive impairment, this test will show those early tendencies much earlier than the other tests. So that's available to you. Now, let's start talking about testing. This is the actual testing, the blood. This is really exciting. Prior to about 6 months ago, we didn't have access to any of these tests on a regular basis. Now we do. And let me show you how this works. This was actually an interesting, and you see the QR code here at the lower right, that you can actually check that and go to the article that CNN put together. This was about a year ago. They put this together. And this is basically a picture, and this is available on YouTube as well, where Dr. Richard Isaacson, who's a preventive neurologist, I love that term, a preventive neurologist. In other words, he's not waiting until you have symptoms bad enough to treat. He's addressing this early on, okay? And he works at the Institute of Neurodegenerative Diseases in Florida. Okay, so he's talking with individuals on CNN in this case, and this is basically a story of Simon Nichols. Now, he had a double copy of the ApoE4 mutation, just like his parents did, and his I think it was his dad who was diagnosed with Alzheimer's early in life, and now here Simon is 55 years old, about the age his dad was diagnosed, and he's got kids. He's going like, hey, isn't there anything that I can do? So he looks up the clinic that talking about testing and what we can do, and so here's Dr. Isaacson meeting with Simon, who's part of 34 or more patients that he had in a clinical trial, showing if you did certain blood tests and then address lifestyle factors that could mitigate that risk and then retest them every 3 months, could we actually reverse the pathology of Alzheimer's in the brain? And that's exactly what they found. Let me read this to you. So Simon Nichols here again has changed his life to battle signs of early Alzheimer's because of his serious genetic risk factors. Okay, so this preventive neurologist, Dr. Isaacson, stared at the numbers on the facts in astonishment. He says the blood biomarkers of telltale signs of early Alzheimer's disease in the brain of his patient, 55-year-old Simon, had all but disappeared in a mere 14 months. Now, this is exciting because this is now available not just for research purposes, it's available to all of us. And what I already pointed out in the lifetime risk of dementia, we're essentially all at risk. The vast majority of us are at risk, especially now. So he said, I had to catch my breath. I was in complete shock. The blood test of his brain had normalized, okay, who was the director of research at the Institute of Neurodegenerative Diseases. Now, so here's the bottom line. This upper part of the slide here shows the summary results of the blood test called Precivity AD2. And I'm going to show you other tests which I think are even more effective in evaluating this. And so basically, if your amyloid probability score is less than 48, if it's between 0 and 47, that's consistent with a negative, that means normal amyloid PET scan. Now, if you've ever priced an amyloid PET scan, you probably would have said, well, never mind. Because an amyloid PET scan, while being the kind of the gold standard to evaluate whether you have pathology of Alzheimer's in the brain, costs about $6,500. And you can imagine why most insurance companies are not in favor of letting you get that test, even though it's a very valid test. Now, the other issue with this is that, anytime you do a PET scan, you're getting that much more radiation. Well, now we have a blood test in different forms available that correlates at a very high level with the amyloid PET scan. Okay, and so if your score of the amyloid probability score is less than 48, basically that's like having a negative PET scan, but it's even better in a sense because it's giving you a number. Sometimes when radiologists give you a report on a scan, they talk in platitudes, like, Well, give me a number. Give me something that I can compare later on rather than talking about diffuse this or, yeah, we got some white matter changes over here. You know, it just may be consistent with early Alzheimer's. Well, okay, that's better than nothing, but it's really not that valuable data-wise. Whereas these blood tests give you a precise number that's highly correlated with the PET scan. Okay, so bottom line is that within 6 months of following the program, the lifestyle medicine strategies, okay, they were able to basically show that nickels dropped from a level of 70, okay, which is 23 points higher into the positive score. So he definitely had a problem. He definitely was showing amyloid buildup in his brain. Okay, he dropped to 53, so still a little high. You're still positive, but it dropped dramatically, 17 points. Another 3 months go by, and he's now down to 40, another 13 points. Okay, and then after 14 months, he's down to 25. That's a huge decrease in his amyloid probability score, basically completely normal. Okay, so that was really exciting that he was able to do that. Now, here's a kind of a little summary of the tests that are available. I personally recommend to my patients what Dr. Del Bredesen recommends, and that is what's called the brain scan by Neurocode, which gives you 3 tests. It gives you the plasma phosphorylated tau 217, which is basically measuring tau and amyloid buildup in the brain and correlating to that. Okay, so a blood test that is approximates very accurately what's going on in the brain with amyloid buildup. Okay, so that's one of the most important tests to measure in the blood. And then there's the NFL, or the neurofilament light chain, okay? And then there's the glial fibrillary acidic protein. More on that in a bit. Okay, these tests are technically available at LabCorp and Quest, but they're not the high sensitivity tests. If you want the higher diagnostic sensitivity, then you want to do the Precivityy or the Neurocode, and I like the direct-to-consumer option of brain scan, okay, that I recommend to all my patients, because you actually get an 8-page document explaining all the tests, and then we can compare that in 6 months. If it's elevated, we can compare that in 6 months and see how we're doing or what we need to change. Okay, so this is an example of the test available, the brain scan, and you can even watch a video with Dr. Bredesen and Julie Gregory talking about, she reversed her Alzheimer's at age 55. She had a double copy APO3E3. And she was going to commit suicide until she said, you know what? I'm not going to commit suicide. I'm going to figure out what I can do, even though my neurologist tells me there's nothing I can do. And she reversed her own Alzheimer's by looking at the medical literature and applying it. She's amazing. I sat next to her at a banquet about 8 years ago for an hour and a half. It was actually at Dr. Bredesen's table, and I talked to her the whole time because she was fascinating, because she did it. She figured out what needed to be done. So bottom line is that the tau 217 picks up biomarkers of Alzheimer's specifically. The neurofilament light picks up biomarkers of neurodegeneration, including head trauma, vascular disease. Or an earlier patient this morning said, I had major concussion when I was young. That's me. From riding my bike, I had major concussions. I was knocked out multiple times. Playing basketball, I still play basketball, and a couple of times I've had concussions playing basketball, and that's really bad for the brain. So all the more reason to pay attention. And then the glial fibrillary acidic protein is a biomarker for inflammation in the brain. So you could have inflammation in your body, like a cardiac CRP blood test, but we want to measure, is the inflammation also in your brain? Is it crossing the blood-brain barrier? And that's what that looks at. Okay, so bottom line is, we're looking at the causes of dementia. It's not just 1 or 2 or 3 or 4. This is a slide from Dr. Bredesen, who says that dementia, and especially Alzheimer's in this case, is like going into a warehouse that has 36 holes in the ceiling and thinking if you just fix 3 or 4 of them, you'll be fine. No, you won't. You're not going to, this is not going to be an inhabitable or usable warehouse or building until you fix the ceiling. You got to fix all the holes. And so that means you got to look for all the holes. And so the approach of the current medical approaches of treating Alzheimer's is all focusing on beta amyloid. And that's just one of the many potential contributors to the pathology of Alzheimer's. There's many, many other factors, and we'll see those in a minute. Okay, so this is a study, sustained cognitive improvement in Alzheimer's disease following a precision medicine protocol. Now, so this was published by Dr. Bredesen and his colleagues, and the key word here is precision medicine. See, the problem is with historical medical application is that they'd apply information from a study that just looked at statistical averages. Well, that statistical average from that study may not apply to you as an individual at all, because you're a unique individual. You have your own genetic risk factors, your own family history, and your own personal medical history. So that's why to address cognitive issues properly, you have to have a precision model. You have to have a personalized model. You have to focus on that person and not just say, well, this study worked for the average patient, so that should work for you as well. No, it's not necessarily going to work for you as well unless we apply the precision medicine protocol properly. So in this study, I'm just going to read this to you real quick, because this really sets the stage for what we are going to be talking about in part 2. And that is arguably the most important parameter in treating cognitive decline associated with Alzheimer's disease is the length of time in which improvement, if achieved at all, is sustained. See, if something improves for just like a month or two, well, is that really worth the trouble of doing everything that you did to get 1 or 2 months of minor improvement? Okay, we need to do something that's effective enough to lead to lasting improvement. And we believe that we've discovered what that is. Okay, however, monotherapies such as donepezil and then memantine and other medications, when you're just using a one medication or even 2 medications to treat Alzheimer's, all the studies have shown that it might help symptoms briefly, but it doesn't change the pathology of the disease. It doesn't change the course of the disease at all. Okay, so the basically they actually, even if they help a little bit initially, they actually lead to a more rapid decline over time, which of course is worse for the patient. So furthermore, anti-amyloid antibody treatments, which are all the rage right now, which at best simply slows decline, is associated with accelerated cerebral atrophy. One of the reasons for this is a new study that just came out in The Lancet in March of 2025, saying, and this is Leqembi or lecanemab. And so there was all being promoted heavily in people that were at risk genetically of developing Alzheimer's. And so they took this for 8 years. And they said if they took this monoclonal therapy for 8 years, that they had a 50% lower risk of developing Alzheimer's compared to the control group. But what the study did not say, at least not in the part that was being promoted in the media, is that initially 1 out of every 5 of the participants who got the antibodies, they actually had brain hemorrhaging. 20% of the participants initially had brain hemorrhaging. So in other words, to get the benefit long-term, you had to survive the initial couple years of the study where 1 out of 5 people are getting brain hemorrhages, which of course would make your memory worse, right? I mean, it's a very damaging to the brain. So you got to be careful when you look at these studies that seem so promising when in fact, if you read between the lines and look at the original research, you realize that you're actually playing with fire oftentimes. So that's why we got to come up with strategies like the comprehensive approaches that Dr. Bredesen promotes that are lifestyle related and natural related, that actually improve cognition even over a decade. In other words, they don't just help for a little bit, they help long term. As long as you follow the steps in the protocol, you will get significant benefit. That's what they're finding in the studies. So basically, in Dr. Bredesen's most recent clinical trials, a randomized clinical trial, they found that of all the patients who joined the program and followed a comprehensive lifestyle medicine approach, that 12% actually got worse. 4% had no change, but look at this. 84% improved, and this is in 1 year. Okay, and this actually was verified by various tests, including brain MRIs. So 84% improvement? Okay, none of the drug trials have ever shown that. None, ever. Okay, the drug trials at best show maybe a gradual decline in the progression, but they're still getting worse. In other words, they have 100% declining. Okay, so that was very exciting to see. Now, let me preface the various steps that we're going to be going over in detail. I'm going to go over all 10 steps right now. Okay, and then we're going to start addressing some of them, and that'll be the focus of what we do in part 2. Okay, to better understand why I added them to the 10 steps. So number 1, the first and most important step is really understand the cause and effect relationship by testing broadly for risk factors and then optimizing, especially for blood sugar and insulin disorders. You'll see why that's so critical. The reason I got so interested in working with Dr. Bredesen is because he proved to me over 10 years ago that the number one most common reason people develop cognitive decline and progress in that and get worse is because of insulin resistance. It's because of the metabolic disorder that causes blood sugars to start to go up. Now the pancreas has to make more insulin, and that extra insulin not only promotes more cancer, more heart disease, and more high blood pressure, but it also dramatically promotes cognitive decline. Okay, and there's some challenges to understanding that properly. So we're going to get into understanding that in depth in part 2. But bottom line is we got to understand cause effect. If you don't understand cause effect, you're not going to put effort into addressing those risk factors, right? Number 2, take advantage of the readily available educational resources. We'll look at that. There's all kinds of great resources available. You want to focus on personalized medicine versus via or through genetic testing. Now, I know that, for instance, 23andMe, that they're in bankruptcy proceedings right now. A lot of people did their genetic testing through 23andMe, and many people are saying we should never do that because the privacy is at risk, etc. Well, really, there's no privacy in medicine. We all know that. We talk about HIPAA and so forth, but really everything is subject to hacking. They got hacked, 23andMe, Google got hacked. Everybody gets hacked from time to time. And so nothing ultimately is going to be private. The key is, are you going to get the information you need to make decisions about your health via your own genetics? And so that's why I'm a big supporter of doing either Ancestry.com or 23andMe.com or some genetic platform that gives you the information that a doctor like me, not necessarily me, can interpret, that they have experience in genetic assessment and can guide you on what that means for you, right? So do the genetic testing, I recommend. We already made a big case for vitamin D testing and optimization. There was a Dr. Angus Dalgleish from the UK, who's one of the top oncologists in the world. He's been doing research on oncology for over 40 years. he recently discovered the main reason why many people don't respond to chemotherapy. And you know what he says? I can't believe it. He says, but one of the main reasons that patients don't respond to chemotherapy and even to immunotherapy is because the vitamin D levels are below 40 nanograms per ml. If you get your vitamin D above 40, that optimizes your innate immune system so much that now the chemo and even the immunotherapy is much more likely to work. Okay, so we'll get into that in more detail. Optimize your vitamin D. That's critical at many, many levels, in particular the brain. Vitamin D promotes what we call the production of cathelicidin, which is one of the most powerful antimicrobial peptides, AMPs, that can go to the brain and actually help get rid of infections in the brain that otherwise lead to dementia. Yes, infections are a big cause of dementia. And I'm talking about even mild infections like colds and flus and various viral infections cross the blood-brain barrier. Boom. Now you got inflammation in the brain that unless resolved fairly quickly through the antimicrobial peptides in the brain, which includes beta amyloid, by the way, more on that later, and vitamin D, we're going to have problems with dementia if we don't deal with that. Okay. So next step, do these 3 types of exercises. I'm going to leave you hanging on that. I already pointed out that walking is very important, that regular sustained exercise is critically important for hippocampal neurogenesis, the development of new neurons in the brain. And so every time I see my patients, each time I ask them, how you doing with exercise? How you doing with your water intake? How you doing with your sleep? How you doing with your diet? And then we get into the more nitty-gritty strategies that are the simple remedies on top of that. But exercise is critical. If you're not following the 3 most important fundamental strategies of lifestyle, diet, exercise, and sleep, those are deal breakers. You're going to have a problem. You can still benefit from the other strategies, but we got to figure those out. I'm not saying it's easy. I'm just saying we got to figure it out. That's really, really critical. So there's different types of exercise that actually stimulate the production of healing hormones in the brain called brain-derived neurotrophic factors that heal the memory cells, heal the synapses, and actually help restore new synapses and neurons as well. Okay, and then test and optimize omega-3 fats. This is so critical. I test every single patient for DHA and EPA, and almost everybody is low. In fact, I would say 95% of the people I test, even the healthy patients, are low in the omega-3s. And that is critical for protecting the brain long-term, both short-term and long-term. And we'll get in, and it's very critical to memory development, memory consolidation, and being able to do things that you once were able to do before. In other words, being able to remember what you were good at previously. It requires optimal omega-3s as well. Sleep optimization and quality, timing, and duration. More on that next time. And then optimizing the diet, foods that heal and foods that kill. There's no such thing as all foods in moderation. There's some foods that are just bad for you no matter how much. Unfortunately, that's true. Okay, and so be aware that you got to make decisions about food, and especially if you're already having issues with cognitive decline, your blood tests are already showing that you have that pre-symptomatic pathology, or you have that subjective cognitive decline or mild cognitive decline, and especially if you're already in the Alzheimer's category, you got to fix the diet, because every day counts. Every day makes a difference on what you eat. So pay attention to that. And then you got to be really wise about alcohol. And I'm going to leave you hanging on that, because there's a lot of data on that is very interesting, and that will help you understand decisions that you make relative to alcohol. And finally, you got to optimize your immune system. If you don't optimize your immune system, you're going to be at risk. And by the way, we are now in a new era of immune dysfunction. of immune deficiency. You know, this whole thing with AIDS, acquired immune deficiency syndrome, most people associate that with HIV. Well, it's not necessarily related to HIV ever. Acquired immune deficiency syndrome just means that something caused immune deficiency. And it can be many, many different things. And so a lot of people are moving in the direction of AIDS. They have immune deficiency that they didn't used to have. Okay, we're going to be going over why that is and what to do about it. So you got to optimize your immune system. That begins with following the 10 steps we already covered, at least in summary. Okay, so let me just end with I'm going to quickly show you this. It was Henry Ford who said, whether you think you can or you think you can't, you're usually right. So if you're still wondering, yeah, I don't know, I'm not really that convinced, okay, then you know you're convinced in your mind, and that will be your reality. So what you want to do is pay attention to those who've done it, and follow what they have done, and you'll get the same results more likely. Now, I'm going to recommend, if you haven't seen this already, this is a documentary that was put together on the work of Dr. Del Bredesen. And basically, it's a formal documentary that's looking at the critics and the enthusiasts. That I actually participated in this documentary. It's really well done, called Memories for Life: Reversing Alzheimer's. And so check it out. You can see it on Amazon Prime. It's on Google, and you can basically check it out at memoriesforlifefilm.com. I highly recommend that you watch that to get more information on this topic. Also, I mentioned, actually was mentioned during my intro, that I actually have like 30 hours of presentations on this topic. So that's why there's a lot of information to cover. Okay, but for my patients and their families, I have on my website a membership program called Reignite Recognition, Restoring Optimal Memory, and that's available at dryoungberg.com as well. So check that out. My book, Memory Makeover, is again the story of this couple where his wife had Alzheimer's for 15 years. And if you want to get a better understanding of how to deal with the immune system, I have this whole series on Rumble. It's called The Rise of Immune Deficiency, Diabetes, Dementia, etc. Okay, and it's on rumble.com. Just type in my name and you'll see all 7 presentations on that topic. And other resources: Diabetes Undone, Reversing Insulin Resistance, a turnkey program that's available online to do that for anybody. And so check that out. And with that, I think I'll turn it over to Q&A.
All right. Thank you so much for all that information that you shared. It was definitely informative, and I don't think there's too many people out there nowadays that haven't been impacted with a loved one that doesn't have dementia. So you shared about your book and the documentary. How would people that want to get in contact with you, how would they go about doing so?
The easiest way is just go to my website, dryoungberg.com, and on it you can see actually you can even get a partial about 32 pages of the book Memory Makeover that has the first 2 chapters and then the chapter on getting labs done. We're going to be going over those labs next time we meet in part 2, I think on April 17. So if you just look at Services tab, click on Services tab, and then go to the Lab tab, and that'll take you right to, so you can download a whole document on reversing insulin resistance, and you can also do a free download of 36 pages of my book, Memory Makeover, that includes chapter 10 on all the labs. And there's a lot of labs that give us clues of what to do, what not to do relative to helping remove risk associated with dementia.
Great. Thank you, Dr. Youngberg. So many people have treated themselves in their youth very poorly. I think it's, kind of like the cultural norm where, even when you look at parents, they feed their kids, oh, they can eat anything, they're fine when they have it. And we get raised eating complete garbage.
Right.
Then it's very common for young people to drink. Marijuana is extremely prevalent now, all these different things. And then at some point, many people feel broken. Hopefully they don't have the Alzheimer's symptoms, but they have many, various issues. And then they start to turn around their health, right? And, when they get to their 30s, their 40s, if someone becomes clean at that point, is the damage already done? And at best, they can kind of just mitigate that damage, or can they really have robust cognitive health in their later stage, once they become, clean enough,
Yeah,
clean.
great question. The bottom line is that the body is very resilient, and the body is designed to recreate itself, to heal itself. So the body's always making new cells in every organ, in every part of our body. And so that's like with diabetes. If anybody's ever measured their hemoglobin A1C, that's actually a pathology test. That's actually measuring irreversible damage to the red blood cell and the hemoglobin protein that has now been caramelized, glycosylated, glazed with sugar. That's irreversible. You can't reverse that. But here's the beauty. How do we reverse your question, right? Your question is, how do you reverse the irreversible? Right? Because it's technically irreversible. That's because the body's always making new cells and getting rid of the old cells, breaking them down. So you get rid of the damaged cells, you make new cells, and as long as your new daily habits don't lead to damage to that new cell, now you're restoring little by little your body organ systems to a brand new set of cells that are healthier than you might have been 30 years ago. Okay, and so that's the key. That's why I refer to the resilience. We need to do daily the things that will help restore us to a more optimal us.
So the damage that you're talking about that's permanent is on a cellular level, but we're getting rid of those cells and making new ones. So even though that damage is permanent, as long as the new ones we're producing are healthy, then we should be good. Because a lot of us really come to health much later in life, and it's nice to know that maybe we didn't do something irreversible, which is what
Yeah,
I'm.
like case in point, in my book Memory Makeover, where I focus on this couple, I had, I was really concerned about even taking them on as patients, because I'm talking to my neurologist friends and, man, what are you doing to me? Like, I want to give people hope, but I don't want to give people false hope. And then that blew me out of the water when I saw the dedication of her husband and figuring out how to make the nutrition work and the exercise work and everything work. And he really got his wife back because he made it happen. And so he allowed every step, all the natural remedies, the simple remedies, to come together to impact her, even though she had less than first percentile function in her hippocampi. She dramatically improved her health because of the daily habits allowed that to improve. A key part of this, Michael, is that when I first started working with him, she had what was called sundowner syndrome. And a lot of people who dealt with Alzheimer's or dementia know what that means. When it comes to late afternoon, early evening, they start hallucinating, they start getting anxious, in her case, she was literally backing up all her clothes in her room and putting them into 2 suitcases and trying to get out the front door, saying, I'm going to go live with my mother, who had already been dead for 30 years. Okay. And so she was convinced that she had to do that. And so her husband, John, in this case, he spent literally 3 hours every evening trying to keep her from doing that. And that had been going on 3 years prior to the first month he saw me. Within 3 months of applying the program, she was no longer doing that at all, which meant that now he had his 3 hours back in the evening and about an hour back in the morning, where he had to put everything back, into the cupboards and so forth. So something like is as dysfunctional to a family unit as sundowning syndrome basically reversed itself in 3 months, even though it had been going on for 3 years. So fortunately, we discovered for her what those triggers were, and we had fixed enough of them where that no longer happened to her. And that didn't come back at all for 6 years until, unfortunately, she passed away from cancer 6 years later. But he got his wife back for 6 years.
Wow. And were you able to speak with her and understand what her experience was from her, because you're talking from his perspective, he had to deal with her.
And
What was her
and
perspective coming, being
actually,
able to
he brought
articulate?
her. I did a conference in Tennessee on this very topic, and he drove 4 hours to this conference. We had 1,500 people attending. It was just a 4 hour conference I was doing on this very topic about 5, 6 years ago, and he brought her to that. And so I got to meet her personally. Other than that, he didn't even have internet. He couldn't do Zoom or anything. I normally do Zoom all around the country. And so he would actually have to go into town, get on a payphone and call me, okay, or another phone and call me. And we did that every month for over a year. And that's how we figured things out. And so, a quick story to answer your question. She did not even recognize her sister and couldn't talk to her on the phone for years. And after about a year and a half on the program, he drove her to Atlanta, about 4 hours away from where they lived. And all the way along, she was going like, "Oh, we're going to see my sister in Atlanta, right?" She remembered the landmarks, and whereas before she didn't remember anything. She had no spatial orientation at all previously, and she could even tell him when he took the wrong turn. That's how much she had regained. And so when they pulled into the driveway to her sister's home, she jumped out of the car, ran to her sister, called her by name, embraced her, and they spoke for the next few hours on the couch, reminiscing about times of old. That could have never happened previous to that because she was more in a vegetative state. So it's one of those amazing things where never think that it's not possible, because many times it is possible. And she got her life back in many respects.
What percentage of patients actually do the protocol steps necessary to help their loved ones regain their cognitive health?
That's a great question, and it's a question of determination and belief, right? That do you really believe that this is possible? Or are you more of a critic and thinking, well, up until recently, most neurologists have been saying, nah, that's not going to happen. It never happens, because they have not been addressing that. One of my friends who actually trained with me when we trained together with Dr. Bredesen about 8 years ago, he's a geriatrician at UCSF. And he said to me, you're so lucky that you can do this with your patient. I go, what are you talking about? We had the same training I did. See, yeah, but I'm in a system where they don't really let us do all these things. And he said, you know what the 3 most important words I teach my residents? I go, no, what's that? He says, I'm so sorry. So when you diagnose somebody with Alzheimer's, you say, I'm so sorry. Not I can help, not, we can get through this, right? But I'm so sorry. And so I've learned the hard way. You never, you can say I'm so sorry, but then come up with solutions, come up with hope, something that gives them an opportunity to be in charge of their destiny rather than giving up.
What is the role of—
Let me go back to answer your question more specifically. Yeah, so there's people, there's family members that, that they go back to their doctor and say, man, we're doing this, we're doing that. The doctor says it's never going to work. So they say, well, so they give up because their doctor told them they're wasting their time. So they call up my office and they say, well, we're not going to continue. So that happens. Absolutely, that happens. And my job is to work with people that are ready to work, and I encourage them. That's why I started out this presentation the way I did, is to give people a sense of the enormity of the problem and what we need to do to fix this or to improve things. And looking at the studies that Dr. Bredesen and others have done, that are showing 86% of people are improving. This is not just an idea of a few of us. This is something that we're seeing collectively amongst the people that are putting the effort into doing the program.
What is the role of medication, with all these, we have all these medications that people are on in various combinations that have never been tested. We don't know what the contraindications are with this cocktail of medications. What's the role of those medications and their side effects with Alzheimer's-like or dementia-like symptoms that may not actually be, or may not have the same etymology as traditional
Okay, so
dementia?
one of the problems, and this is something that Dr. Del Bredesen has written at length on, and he's a neurologist and he's been doing research for over 40 years on neurology. And so when he presented this initial study to the NIH, to approve, they said to him, that's not how we do research. We just look at one thing at a time and see if it helps. And he says, well, apparently you don't understand Alzheimer's, because Alzheimer's is not one thing. You're never going to get good results by doing one thing. And so that's one of the key problems with the scientific method as applied to Alzheimer's, is that it was actually Dr. Sidney Baker from Yale University Medical School that used to say, if you're sitting on a tack, it's going to take a lot of aspirin to make you feel better. But if you're sitting on two tacks, removing just one of them doesn't make you 50% better. So the analogy with Alzheimer's is that, what if you're sitting on dozens of tacks, and you remove a dozen of them? Though each one you remove, Michael, is necessary to get better, okay, but it's not sufficient. You have to remove as many of them as possible. And physiologically, we're not ever going to be able to remove all the tacks because we don't even know what all of them are yet. Okay, but if we remove enough of them, the body, through its self-healing mechanisms, is able to make up the difference many times. And so that's why you asked about medications. Medications can have a role, and they're having their role on that pathophysiologic mechanism. Okay, that might be really necessary, but not sufficient. That's the key to understand. And so, yes, medicines can have their role if they're vetted properly for that person. Remember, precision medicine, personalized medicine. So if somebody has pneumonia, you're not going to say, well, we're not going to give you antibiotic because, there's this problem with antibiotic resistance and we don't want to promote that. Now, if you have pneumonia that's bacterial origin, you treat it with an antibiotic. You get rid of the bacteria. By the way, as I alluded to earlier, any lung infection, any sinus infection, really bad for the brain. We've always known it's bad for diabetes, which indirectly is bad for the brain, right? Okay, but because anytime you get an infection of any kind, even a urinary tract infection, okay, that's really bad for your diabetes. Blood sugars go way up, and that's indirectly bad for the brain. But more importantly, we know that if my Alzheimer's patient gets a urinary tract infection, their dementia gets exponentially worse during that infection, to the point where they're oftentimes hallucinating. I mean, it's really bad, and they're like leaning to the side, and they're having all kinds of weird symptoms. So, in other words, if you have, I was talking to a friend of mine who's a family physician, Dr. Madrid, who said that maybe when somebody has a negative response to a urinary tract infection and they start having mental problems, then that's a sign of early indications for dementia, potentially. Okay, so in other words, there's all kinds of early signs of we're moving into the realm of dementia, and infections and chronic infections are really bad news for dementia. We got to figure that out and follow the appropriate drug therapies to treat those.
Thank you. So, how can we tell the difference between, or can we tell the difference between the various types of dementia? You said that Alzheimer's is the least worst to have. And does that even matter with regard to how we would treat these various kinds of dementias?
Well, it's so again, the good news, the reason I said that is that when somebody gets diagnosed with Alzheimer's, oftentimes there's this fear and foreboding, like, oh no, this is horrible. The big A word is worse than the C word. It's worse than having cancer in many cases, they think. But what we're suggesting here is that we now have a protocol, that a comprehensive protocol that we can personalize to really help people out. And so the key here is really focusing in on the strategies. And what was the second part of your question?
Does it even matter with regard to the strategies?
Oh yeah. So in a way, the strategy should be applied to all forms of dementia. Really, in reality, what we're really dealing with is a highly complex disease. So the more complex, the more unsure conventional medicine and science is on how to treat a condition, the more you need to take this multifactorial, broad approach where you're leaving no stone unturned and you're trying to fix as many things as possible in hopes that the body starts making the additional adjustments necessary to get improvement. And so having said that, I would apply that to any form of dementia, the strategies that I just outlined. Those are general strategies. Okay, now, it's true, though, that if you have frontal temporal dementia or Lewy body dementia, that you're probably not going to get as significant a beneficial response, okay, than somebody who has an Alzheimer's type dementia or a vascular type dementia, which are the two most common forms of dementia. But again, the earlier we evaluate risk factors and treat them, the better off we're going to be long term.
You kind of touched on this with the urinary tract infection, kind of giving a hint to dementia when there's cognitive issues that go along with the urinary tract infection. There are other medical issues that tend to pre-dementia that could be a foreshadowing that dementia is down the path.
Well, one of the areas that we won't actually get into in any depth in this two-part series we're doing is dealing with mold. And maybe you have some other speakers that are addressing that, rightly so, because I actually evaluate mold through urine testing, through home testing, and through blood testing to look at what we call HLA susceptibility to mold or biologic toxins. And I do that in every patient who has a complex condition. And by complex, in this case, of course, any form of dementia, okay, but also conditions that aren't responsive to conventional therapy. In other words, the regular doctors are doing everything that is reasonable, and the disease is still progressing. So then we start looking at what are the other potential contributing factors, and one of them that frequently is overlooked in conventional medicine is mycotoxins. And so I tend to do urinary testing using a mycotoxin profile, which are toxins that come from pathogenic mold spores, which there's a few, there's a dozen or so that are very serious. And if you have high levels of those spores in your home because of even a little bit of water damage somewhere in the kitchen or the master bathroom, now you're breathing in a mold that is being generated by these mold spores, and that, especially in those of us that are susceptible, which I'm one of those because I've tested myself and I'm super susceptible to mold toxins, and I never considered my mold being a problem. I lived in Guam. I worked in Guam as a medical missionary for 14 years, and throughout the Micronesian islands where there's mold everywhere, right? And I never thought twice about the mold that I was exposed to, not realizing that it was building up in my body because my body can't break it down very well. So some people can handle a lot more mold. Other people exposed to even less mold, they have problems, and it's really bad for the brain. It's really bad for diabetes. It's bad for heart disease. It's bad for the immune system in general and cancer risk. So more on that sometime in the future.
Yeah, well, I'd love to hear just because I think it's so common. We all live in houses and it's impossible to keep them up and there's water damage. How do we clear the mold out of our body if we, if we're exposed to
Well,
that?
it depends on our susceptibility. It's kind of like how long do you need to drain the swamp, until it's drained, right? We do serial testing on ongoing testing, I should say, on how much mold toxins are in your body. Ironically, Michael, is that some of the most toxic patients are the ones where we do a urine test and there's no mold toxins in their urine. And then the question is, well, is there none in the urine because there's none in the body, or is it because the body's not able to release it? Okay, and so that's where we do what we call provoke testing, where we give glutathione and do a sweat session the night before the urine test, and the glutathione and the sweating help draw the toxins out of the organs into the blood and therefore into the urine. And now if we see it, then we know there's a problem with holding on to toxins. That is one reason I like to do what's called the HLA-DRDQ blood test. HLA stands for human leukocyte antigen, or interpreted in normal English, it's the proteins on the surface of the white blood cells, the leukocytes. And if those proteins are of a certain nature, they make you much more susceptible to any biologic toxin, toxins from bacteria, toxins from mold, toxins from Lyme, etc. And that, of course, increases risk for serious long-term immune deficiencies.
So you talked about insulin, you talked about diabetes being Alzheimer's of the pancreas. I've heard Alzheimer's being called type 3 diabetes. Is that the same thing, or is that is
Yeah,
that a
yeah, it's
two-year
basically,
relationship?
and we will actually get into that immediately in part two. That's actually the first next section that I'm going to be addressing is how to assess this being a problem. So that's why I'm a big fan of doing what we call 3 or 4 hour glucose tolerance testing, where we're measuring the fasting blood sugar at the lab. Then you get a 75 glucola drink, which is a carbohydrate drink, about 300 calories of carbohydrate, like a medium Sprite. And we see how that impacts your blood sugars, but more importantly, how it impacts your insulin production by your pancreas. So we can precisely evaluate how insulin resistant you are, which is one of the main drivers of heart disease, cancer, and dementia, but also at the same time see how functional your pancreas is in producing insulin. And we compare that insulin level to the blood sugar level. And so this is unconventional. It's not what most doctors do, but I've been doing that test for 35 years now. It's the single most important test, in my opinion, to understand what drives dementia, heart disease, and cancer risk. And um, and uh, and so we basically, once we get that information, we oftentimes, I have patients get a continuous glucose monitor, which you can get now with Stelo. You can get it over the counter, for 14 days. You just have it on your arm. You can check your blood sugar at any time before or after meals. And you get instant feedback. I'll be going over this in detail next time. You get instant feedback on how your lifestyle, your stress levels, your diet, what you eat, your snacks, your exercise, when you exercise, how all that impacts your blood sugar levels. Most people have no idea what their blood sugars are after eating 1 hour. Okay, and when you have a continuous monitor, you can check that all the time. You can check it while you're sleeping, etc. And that is really critical, because one of the things that's really bad for the brain is a high blood sugar. The next thing that's really bad for the brain is a high insulin level. The next thing that's bad for the brain is a low insulin level. So you want to have the right amount of insulin. And finally, if you get a low blood sugar because of extra insulin for a little bit, that low blood sugar is like the worst thing for your brain, because that your brain literally starts blowing up memory cells. And that's when your body produces a lot of cortisol, trying to fix the problem. And that extra cortisol is also bad for your brain. So we have this roller coaster of hormones that are initiated by insulin resistance and metabolic syndrome. And we'll be covering that in detail on April 17 when we do part 2.
Great, thank you. So we're out of time, but I want to ask you one really quick question. Marijuana has become so prevalent today. Everybody, every mother's is, taking gummies before they go to bed and whatnot. And it's made to seem like it's benign. It's almost like it's good for you. What are the impacts of things like marijuana on and Alzheimer's? And just the real quick answer.
Okay, so the quick answer is this. CBD is really good for the brain. It's neuroprotective. THC is neurotoxic. So that's the short answer is I love CBD. It's anti-inflammatory. It's powerful for lowering risk. It's good for the brain, but THC is not good for the brain. It might be good for some other things. It's not good for the brain, especially when used regularly.
Great. Thank you so much, Dr. Youngberg. It was really informative. I really appreciate
My pleasure.
it. And this topic affects so many people. If we can unmute the audience, please.
Thank you.
Thank you.
Thank you.
Very
Thank you very
Is there
much.
somebody who
Thank
can?
you. Thank you. Thank you.